Hello, Namaskar. Hello, everybody. Greetings from Confederation of Medical Association of Asia and Oceania. I'm Dr. K.K. Aggarwal, the president of CMAAO. This is our weekly meeting. And this is a special meeting because we are now discussing one particular country and we will put down all our opinions on that. I have with me Professor Ashraf Nizami then also I have Mari. I also have with me Dr. Chong. And the speaker for today will be Dr. Jamal Uddin Chaudhary from Bangladesh, who will be presenting his data. We will evaluate, all of us will give our opinions and see how our country's various programs can help Bangladesh in achieving this problem. I'll request Dr. Chong to chair this session. Dr. Chong to introduce and chair this session.
Thank you very much, President. This is our usual weekly meeting, and we look forward to hearing from our Bangladesh colleagues about their situation at home. Please proceed, Dr. Jamal.
Thank you very much. Good evening, everybody. I'm Dr. Jamaluddin Chaudhary, representing Bangladesh Medical Association. Today, I will represent briefly, actually, not in detail, the COVID-19 situation in Bangladesh. So if you please allow me to share screen so I can go with the PowerPoint. Would you please allow me to share screen?
Yes, he's doing. My IT team is doing it. Saurabh, kindly allow them. Saurabh, kindly allow Dr. Jamal to.
He's allowed.
Thank you. Thank you very much. Now, you see, Bangladesh is a heavily populated country. It's near about its population size is 164 million. Can say, and the area is 147,570 square kilometer, and population density is very highly dense population, most dense population of the world actually, 1,116 per square kilometer. We in Bangladesh on 8 March, the first case of COVID-19 was detected and declared officially. So far, number of lab tests done is this is 100,091. Sorry,
1 million.
1,091,870, and test conducted per million is 6,629. You can see we actually the number of tests have been reduced these days. It is said that the government has imposed a nominal charge for tests these days. So after that, a bit it's reduced. Even the flood situation also is going on in Bangladesh. It's prevailing here. So that may be also one of the reasons behind the reduced number of tests. Private facilities are permitted to conduct corona tests by their own RT-PCR machine. Just a few days back, it has been permitted. And the number of tests reduced, I told you because of this. But when the private facilities are permitted, so it was supposed to increase because the people got the chance to go for a test. But we're not sure for what reason actually it has been reduced. Bangladesh has not yet started antigen test. No antibody test also started for surveillance. Number of confirmed cases is 218,658 till now. Number of deaths confirmed due to COVID-19 is 2,836. And you can just see number of total death is documented or undocumented, indicate the total number in the infected cases. So I do not know how we can explain actually why the number of tests is responsible for less detection, or it is the prevalence is less. That has to be actually decided, because the number of deaths you have seen, it's not so high actually in Bangladesh. So we are showing the death cases almost similar in India, 35 to 50, something like that. One day only it has gone to 64. Of course, it is just only confirmed death cases. We just hear some undocumented cases also here in Bangladesh. Maybe it is per day, not more than 15, you can say. So usable ICU bed that is dedicated for COVID-19 cases is 201. Uh, ICU bed occupied is only 133. So the serious cases and critical cases, the number of critical cases are less actually. The number of general beds is 7,232 dedicated for COVID-19, and number of beds occupied only 2,450. So it explains actually the people having positive in the diagnosis, they stay in the home mostly until and unless they need further assistance like oxygen and other assistance. So initially there was shortage of high flow nasal cannula. Actually, it was severe shortage was there. Now it is okay now. So probably initially the people actually died because there was actually shortage of high flow nasal oxygen supply. Initially, private hospitals and clinics were not providing any service. Now they are giving service both diagnostic and curative. Hydroxychloroquine is not used in Bangladesh when actually WHO has just curtailed it from its solidarity trial. And so we have just stopped giving, and ivermectin is not advised in the national guideline, but the patients are taking randomly. You can say some doctors are giving and people, because it is cheap, so people are probably they are taking hard. A clinical trial is going on with the approval from Bangladesh Medical Research Council on ivermectin and doxycycline together. Two trials are going on. Healthcare workers who have treated patients and became infected have faced social stigma from local people. And I can say the number of doctors infected is very high. It's 2,229. Initially it was too high, but now it is decreased now, nowadays. Number of doctors deceased is 68 due to COVID-19. Most of them, they are on duty actually. Supply of PPE is not satisfactory, is now satisfactory. Initially, there was question about its quality. Now, probably it's better. And contract tracing is going on, but it is very insufficient due to shortage of employees or volunteers. Wearing mask has been made compulsory by law recently. Bangladesh government ordered for 45 days lockdown at the beginning, but it was not observed strictly. At present, no significant lockdown program is on implementation. And so you can see in graph, actually, I can just tell you that confirmed cases by age group, if you see, that is 1 to 10 is 3%, 11 to 27%, 21 to 30 is 26%, 31 to 40 is 27%, 41 to 50 is 17, and 51 to 60 is 11, and more than 60 to 7%. So you can say it's more years are getting the infection, and the death actually is just reverse. Actually, it is a 1 to 10 age, it is 0.82%, 11 to 20 is 1.49%, 21 to 30 is 3.4%, 31 to 40 is 8.29%, and 41 to 50 it is 17.39%. And 51 to 60, it is 29.62%, and 60 to 60 above, it's near about 26%. And if you see cases by gender, it is female is 29 and male is 71%. Deaths by gender, female 23%, male is 77%. So that's all from actually from Bangladesh till now. Thank you very much. And now I'll go for the, thank you so much.
Thank you, Dr. Jamal.
Thanks.
And I look forward to any questions from our participants.
So I would like to add I like to compare it with India experience. India, Pakistan, Bangladesh, Nepal should behave the same as far as I'm concerned, because there are no racial differences. We all have lived in the same environment. we all have the same hygienic status. We all have the same innate immunity. Therefore, our behavior should be the same. Now, if we see Bangladesh, the mortality is approximately 1.2 or 1.3%. Now, Delhi data now has shown that in Delhi, where the disease has now restarted regressing, the mortality is 0.3%. In Delhi, 22.8% people have developed antibodies. It means the actual mortality is 0.3%, and the same is seen in Kerala, the same is seen in Sri Lanka. Therefore, actual mortality of this in our country should not be more than 0.3%. Now in Delhi, for every one case confirmed, there were 30 unconfirmed cases. So whatever your data is showing, number of beds, when you say there are 218,658 cases, multiply it by 30, that will be the actual number of cases. And with that, your mortality again will come back to 0.12 or 0.13%. The very fact the mortality is low, that is the reason people are not accepting the lockdown. People are staying at home, because if this was a high mortality, everybody should have rushed to the people. So one thing is, there is a consistent finding, and the same observation should come back from Bangladesh, from Pakistan, and I expect the same thing in Nepal. So mortality in our countries is between 0.1 to 0.3% and not more than that. Therefore, this is not a deadly disease in this part of the Asia. That's one. Number two is ICU bed requirement is less than 1%. I'm talking about, when I say ICU, I talk about the ventilator. Ventilator requirement is less than 1%. And that is, if you say your number of beds are, your number of beds should not be more than 1%. Rest all can be managed at home, at nursing homes, at smaller hospitals, as long as you have high flow nasal cannula, and as long as you have a high flow nasal cannula and a BiPAP machine, the mortality we should be able to reduce. Number three, amongst doctors, if the number of deaths are higher, we have approximately 110 deaths. You have 68 deaths. These deaths now should reduce to as low as possible, because now we are recommending that every doctor who is in a COVID duty, minus AII room. Our number of deaths are because we don't have a AII room. And because of that, we have a very high viral load. An increased viral load in us is causing thrombotic episodes. Our doctors are dying because of pulmonary embolism. I have a number of people where we have confirmed that the death was due to pulmonary embolism. Therefore, I say doctors should be started early anticoagulation. And if they develop thrombotic complications, in spite of having a low molecular weight heparin, they should be treated with a tenecteplase, because they should be giving a fibrinolytic agent to save them. I am seeing most of the deaths in doctors I'm analyzing. A, they have not received tenecteplase as a last resort. B, they have missed the diagnosis on day 3, day 4, day 5 of pneumonia. So if you miss your diagnosis on day 3, 4, 5, it is a problem. We in India have come back a very simple protocol that all patients with COVID, they must identify their day 0. Day 0 can be any atypical symptom is day 0. And on day 3, 4, 5, if you measure your SpO2 level and you say my exertional SpO2 level doesn't fall more than 5%, or my exertional distance, 6-minute walk distance is the same, you do not have pneumonia. You do not have oxygen-dependent pneumonia. You may still have a mild pneumonia, and these patients are going to recover. All those cases on day 3, 4, 5, 6, if you can pick up exertional dyspnea, which means they have a pneumonia along with a clot. Pneumonia along with a clot. At that particular moment, if they are given a combination of antiviral, if they are given low molecular weight heparin, and if they are given corticosteroids, they all should recover. If you remember that in old age, in our Hindustan, we used to say pneumonia or bigda hua pneumonia. That used to be the common terminology we used to use before 1947, that he died of a double pneumonia and he died of a pneumonia bigad gaya and he died. And that double pneumonia is viral pneumonia. And when you say bigda hua pneumonia, that means we have missed the diagnosis on day 3, 4, 5. Now the pneumonia inflammation because of the clots have extended all over and hypoxia has developed. Therefore, I congratulate Bangladesh that they are also learning the same lesson as we have learned. And now Bangladesh, Pakistan, India, Nepal, because we have the same demographics, we have the same pattern. Now China, Hong Kong, and Singapore and Korea are ahead of us only in one thing, because they have AII rooms. We don't have. We have AII room only in selected places. Therefore, because they have a good AII room, there was a time we used to think they are the best ICU care, but now we are talking about only 1% need ICU care. Therefore, our resolution should be that in a countries, we should follow the model of Singapore, Hong Kong, and South Korea, build up AII rooms so that we can protect people getting cross infections and reduce the mortality. The mortality among doctors today should be zero, but it is not going to be zero because our viral load is higher because of repeated exposure to the patients. That's what it is happening. Mask is compulsory, should become compulsory forever, because how long this immunity will last, we don't know. And I'm 100% sure that COVID 2020 will come much earlier than COVID SARS-2. The Corona SARS-3 will come much earlier than anticipated. Corona SARS-1 came in 2009. It took 11 years for SARS-2 to come. SARS-3 will come. You cannot leave it. It will come because it is a trend. And normally we say pandemics develop every 10 years. So SARS has already proven, because when I was in MBBS, we were told that pandemics are supposed to occur every 10 years. So therefore, the next pandemic, when it will come, we don't know. But SARS-3, if it comes, it will be much earlier for that. Hydroxychloroquine will practically have no value if you are giving steroids. Hydroxychloroquine is an anti-inflammatory drug. Therefore, its role was till steroids were not given. Once you have given steroids, no other anti-inflammatory drug is required. Even NSAID will lose its role if you are giving steroid, because they are the most potent anti-inflammatory drugs. If you are giving an anti-inflammatory drugs, the role of antibiotics will also go. Now antibiotics are being given not as an antibiotic, as an antiviral, but because of covering steroids, that steroid should not cause any other infection. Therefore, the role of broad spectrum antibiotic will persist with steroids, but the primary role of antibiotics, I think, is gone. There is no role, because now I have large experience where people recover without any drugs, where people are recovering without any drug at all. So this is typically behaving like a virus in those particular cases. The cost, yes, wherever you indulge some, if you say that because government has put some cost, therefore number of tests have gone down, I probably feel people have now realized that if one person is positive in the family, other people, they presume them to be positive. Therefore, number of tests in a family will be one. We in India are initiating, and I am trying to talk to few laboratories to start a pooled test. Pooled test means there should be two tests done, one of the patient and second pooled test of the family. So if the pool test of the family is negative, you are sure nobody else is having it. And if you find that pool test of the family is positive, you presume everybody in that family is having it. It may be one, but if another person is having it, you presume sooner or later everybody is going to be positive, and accordingly you can take a public health initiative. So we are recommending that two tests, one for the patient who is symptomatic, and all asymptomatic members in the family should have a pool test. The Singapore experience says 64 pool tests can be done. Kerala government says 20 pool tests can be done. ICMR says 5 pool tests can be done. And I totally agree with you that lockdown now is not the answer. Lockdown is not going to it is only going to postpone your miseries. This disease is not that serious enough that you require to do a persistent lockdown. All yours, Chairman.
Thank you, President, for that very enlightening summary, and of course the experience of the countries, of your country and countries around us. Do I have any questions from any of the participants?
May I say something?
Yes, please.
Please, sir. Yeah, one thing, I think it is not the treatment lockdown, as Mr. President says, that it is not answer, but I believe as one of Pakistan, what we achieved, that the lockdown is the only answer, because we believe, and I believe too, that prevention in this disease, which is important, that is the prevention. And for prevention, only we can do when we have a lockdown, you call it as a small lockdown, or as it is the recommendation by the WHO, that 7 days lockdown, then you release. And lockdown is only answer just to strengthen and make the availability of the health services, the workload on the health services by the infection of COVID-19. That is only. Otherwise, it is nothing to do with the treatment of the patients or control of the disease. One thing. Secondly, that we have done here some tests of antibodies, and what we have come across that 30 to 40% people have been developed antibodies, asymptomatic. And there are certain colleagues, scientist colleagues in Pakistan who think that in September, we may have about 60 to 70% people who will be infected and develop the antibodies. Meanwhile, the idea of the lockdown and the herd immunity is under discussion nowadays in Pakistan, that whatsoever we do, because unfortunately that we don't have a good lockdown, as the Australians, I'm sure that all friends are very much aware of and should be aware of, that what is happening in Australia, the Victoria, that is a case in case of this COVID-19. So having said what I believe, and I want to share, that the lockdown has still an answer, and why people are not coming to the health establishments, the reason being the virus load that has been reduced, and mutation has made the virus soften, not as it was in the start, I mean by the March and April. So this is one of the reasons why people are not, as Mr. Chaudhary, he said, that people are not coming to the health establishments. The reason being, one is the services over there, and secondly, now it is the mild transfer of this COVID-19 which is happening in the society. Thank you very much, Mr. Chairman.
I just want to add what Dr. Ashraf has said. Initial lockdown is fine, but continuing lockdown will not be the answer. There is a theory behind that. There is a scientific theory behind that, that if you continue a continuing lockdown with large number of people in a house, and most of them at house will not wear mask unless you have an extended lockdown with mandatory mask at home. So if one person of them is positive, and if he stays at home for 7 days, everybody is going to develop the infection. So you are transferring the infection from community to house. And that may be the reason that that in India, we did the same mistake. We took the lockdown out, allowed people to mingle, and did not mandate masking at home. If you do not allow masking at home, everybody in the house will be infected. And that's the reason our first wave in Delhi belonged to families, joint families, not nuclear families. So in Pakistan, you have most of them as joint families. Bangladesh, joint families. So if you are going to extend a lockdown, all joint families will get infected. If that is the criteria for developing herd immunity, it's fine. But you are shifting the transmission from community to family. For when the virus is not there in the country, lockdown is understandable, because now you are one or two cases, you are trying to localize them, it's fine. But now when we know 30% of the people already have got infection, if you are further going to lockdown, it means you are allowing the infection to come in joint families.
Well, Mr. President, if I am allowed, Mr. Chairman.
Go ahead, please.
Yeah, thank you very much. One thing that it is not that you are getting from the community to the family. The question is that once it is the symptomatic patient, then certainly patient should not stay if it is the severity or so on. And one patient, if they do not have the facility for isolation for a patient, certainly we need a patient to be hospitalized, and patient should attend in the hospital, not in the family, one thing. And secondly, which is my opinion, that it is not from the community to home. It is other way around, that from home to community, we are going to prevent it. This is what I think. And you are right, partially.
When I say, Ashrafji, from community home means
Yeah.
that if I am working outside and I am doing a public meeting outside, suppose I am a shopkeeper. So I brought an infection from my shop, that becomes community. And if I come back home and go back to the shop and stay 24 hours at home, that my contact time with my family increases. If I have carried an infection from my shop, I will give it to everybody in the next 7 days. That's what I mean from community. Community doesn't mean that somebody else is bringing. I say, if I am in a community, I am a shopkeeper, I am having public dealing. And when I come back and stay at my home for 7 days, I am having a contact period with my family much more. Daily, I may have only 1 hour in the night for dinner. Now the whole day I'm spending time with them. So therefore, I'm likely to infect my family. Therefore, if we are allowing people who have been doing public dealing as an extended lockdown, we must mandate masking at home and social distancing at home. If you are not doing, see, like doctors, when they are doing a duty for 7 days, they are not allowed to go home. They are allowed only to a hotel. So in India, if you are a doctor working in a COVID center, after 7 days of duty, you are allowed to stay in a hotel, not go home. And in 5 days, if you don't develop symptoms, on 5th day, if your test is negative, then only you're allowed to go to your home. So if a person who is in public meeting, if he is going home, he can carry infection. And if he's made to live in the same atmosphere, he can cause on the infection. This was the reason of infection in Delhi in large segment of the society, because we have seen them, every family, 23 people in one family got it, 10 people got it, 17 people got it. Another observation of ours is there is nothing like asymptomatic. People are missing the word symptomatic. A headache can be a criteria, left eye involvement, partial 2-hour loss of smell and taste, simple single loose motion, simple 2 hours rash, simple pain in jaw, simple pain in, they may have cystitis, they may have urinary problem, they may have nausea or vomiting. People are not considering them as symptomatic. People are taking these, that means there has to be a fever, there has to be cough, there has to be breathlessness. But that is not present in 70% of the cases. So therefore, when we say asymptomatic, definition of our government is wrong, because people, what we are getting is asymptomatic actually have slight sore throat. This is, I had a sore throat for 2 hours, then it recovered. That was day one. That's what I'm trying to say. Most of them will have some symptoms which they will ignore.
But can I say,
second thing, may I continue, Mr. Chairman?
Yes, please.
The question, okay, one is the workload, virus load. We have an idea, and we in Pakistan over here, we asked the government to reduce the virus load. That is by that not the 36 hours working days or 8 hours, it could have been reduced to 4 hours. And if we reduce this working hours to 4 hours, we believed over here, and I believe too, that we can reduce the virus load, and certainly the infection amongst the health professionals that could have been reduced. Very unfortunately that we have a virus load over here, and that is, I think that is one of the reasons that we are having over here the infection for the health professionals. Thank you very much.
Thank
Dr.
you.
Sajjad.
Yeah. Hello. Yes.
Yes.
Thank you very much. Good morning, everybody. I'm sorry, a little bit late. I am actually. I just want to endorse what Dr. Aggarwal said about the symptom, asymptomatic. It is absolutely right. He is absolutely right that being a ENT surgeon, I'm working in Karachi as an ENT surgeon. What I observed that the patient came with a simple complaint that he has she has a simple sore throat or sometime nasal obstruction and sometime loss of smell for the last 24 hours. And when I get the reports, it's a COVID positive. So this is very important to note that a single symptom can be a corona positive, and that the people should know about that. And most of the time, people deny that this is happening all the time to me. It's not a corona. I have this problem since so long, but this is a simple problem, and it started just last night. So it should be considered as a coronavirus, and you treat them as a coronavirus. Secondly, it's a government responsibility. I think that the public should follow the SOPs while they are working in their respective jobs, and there should be a strict following of the SOPs. Otherwise, this virus will continue spread, and it will spread and spread. Thank you.
May I
Thank
raise a
you,
question
Dr.
actually
Sajjad.
to Dr.
Yes.
Aggarwal? May I raise a question just to Dr. Aggarwal? Dr. Aggarwal, could you please explain actually, do you have any sort of data that you have said that 1:30 is a just asymptomatic symptomatic ratio? So
there are a
do you
couple
have
of
do you have
data.
any? No. I'm not finished. So in that asymptomatic cases, did you have those symptoms actually which we have ignored actually so far? That it may be a symptom of the single symptom of the COVID. So that we can come to the conclusion, that actually the whatever we are saying the asymptomatic and we're tested positive, so they are not actually asymptomatic. They have some sort of symptoms. So we could go to that actual inference.
I will give 3 or 4 examples. One example came from the largest study in China. And in Wuhan, they have 6 cases, they were found to be positive, symptomatic. So they checked 65 lakh people, 6.5 million people over 12 days, and they did RT-PCR. And this is the largest study available in the world. And they found 200 patients who had not reported symptoms. So there is a difference between the words asymptomatic versus reported symptoms. Okay, so there were 200 people who did not report any symptoms. So therefore, they considered that the ratio is 1:30. Okay. Now my personal data says for every one detected person, 20 undetected, one tested person, 20 people are getting treated without testing. Either they can't afford, or they are afraid, or they are a joint family members. They say if one is positive, everybody is having the same symptom, why should we go for test? So therefore, because they say that if the 9 people, this is one reason. Another thing was a policy of individual isolation, initial policy of individual isolation. If husband and wife are positive, they will be taken by the hospital and they will be put in different wards, not together. That made 50, that therefore if the husband is positive, the wife will not declare that I have symptoms. She will follow the treatment at home. So therefore for every one person, there were 20 people who were getting treatment, but they had not got themselves tested. That's what another ratio. Third example comes from a survey from Bombay, which shows 28% people are seropositive in containment zone. So there is a rider there. In areas with high prevalence, the antibody detection rate in Mumbai is 28%. in Delhi is 22.8%. And in Delhi, they have not taken children into account. Okay. Now, once we say 22.3% rate is positivity, we multiplied the population of Delhi. It comes out to be approximately 40 lakh people who are positive. And the reported cases in Delhi is only 1 lakh. So we presume it is 1:40. So in America, it is 1:10. So our interpolation 1:30 is based on number of cases which are antibodies tested and number of cases reported by the government. So for all practical purposes, the ratio comes out to be, see, America says 1:10, New York says 1:28, that's in New York. Then we in Delhi says 1:30, China says 1:30, and now whether it is 1:10, 1:20, 1:30 is only a number. So we say more than 10% of the population is affected. This is one. Number two, number of people dying multiplied by number two. That is the actual number of deaths because of COVID. A, those people who die at home, we don't know because the COVID test is not done. B, those people who die and the COVID report comes after 3 days, they are reported as negative initially. Nobody changes their numbers in the government sector after the report comes. Nobody follows that reports. This is number two. Number three is all those people who have died after 9 days, the government is not considering them as COVID. Because if a person after COVID dies with a heart attack on day 28, it may still be a post-COVID complication, but he is not included. Therefore, there is a rough estimate that whatever a number of deaths in the government says, multiplied by 2, that will be the actual number of deaths. Whatever are the reported cases multiplied by 30, that will be your actual cases in a condition where we are talking about highly congested areas. Now, these equations may not be valid in a non-congested communities. So in India, when we anticipate, so we anticipate a ratio of 1:30. Thank you.
Thank you, President. Any more questions from the floor?
Just one thing I would like to share, that the discussion or the statement by the Honorable President, that symptomatic and asymptomatic. But the short term, these symptoms, he has said that it is for 1 hour or 2 hours. Unfortunately or luckily, there is none. I mean, a person who has those symptoms when the COVID was not over there. So it is, I think, to my understanding, it is difficult to declare that any symptom person has. And certainly, if you investigate that symptoms are over there, the short-term symptoms. But even a healthy man, you will get it, because in our country, when you have some cold drink, soft drink, you can have that you have covered with some problem or so on. So it is a tricky question or tricky investigation that to say and declare that it is the symptomatic or totally the non-symptomatic. But it is just as a scientist and just to be the end observation, nothing else, Mr. Chairman. Thank you.
Another thing is when we say asymptomatic, we miss pre-symptomatic. The reason being they develop symptoms. Suppose the test is positive today. 2 days later, he develops symptom, but on the statistics, it has gone as asymptomatic. Actually, he's pre-symptomatic. He's going to develop symptoms after 2 days. So that also is statistically, people are not following them. They only check at the time of diagnosis. At the referral slip, it says no symptoms. So all pre-symptomatic cases actually are being declared, actually are statistically taken as asymptomatic. That's what I'm trying to say.
Mr. Chair, can I just raise one point actually? The other day, actually, I raised one thing that whether we can come to a decision that we can suggest to our government that what measures actually should be taken now actually. That is whether only the masking and the social distancing, no lockdown, is it enough?
I can tell you the issues in India. There are still issues going on, home monitoring or not. Home monitoring, wherever has been allowed, they have been able to check the disease. In whichever state home monitoring is not allowed, the disease is not being checked. So we have various types of examples. The classical example is home monitoring with a strict home follow-up. That's Kerala. Kerala is a strict home follow-up and home monitoring. They have the lowest incidence. Delhi, home monitoring is allowed. Bombay, home monitoring is allowed. So the number of cases are reducing. Now the case went to High Court. In UP, in Uttar Pradesh, the High Court intervened and they said government cannot say no home quarantine is allowed. Now there is a High Court interference, and High Court interference is home observation is as good as a non-home observation. It's an individual right. You cannot force an asymptomatic person to stay in a hospital. That's his right. So government can come back with the guidelines. What should be the guidelines where home quarantine is allowed? So one thing is a matter of home quarantine, which will vary from country to country. But the observations in India is that home quarantine is a good choice. That's one. Number two is that day two, day three, day four, day five, now we are getting a consensus of the experts. It has still not been declared by the government policy, but all the experts in the India now are of the consensus that day three, day four, day five, if we do a SpO2 level exertional, and if there is a fall by more than 5%, it's a serious case. This is a consensus developed by the private doctors in the experts in the country, but still it has not been converted into a policy with that. In India, we still have antigen test is allowed. So therefore that can be one policy, but this antigen test will be 50% positive. Sensitivity is only 50%, but specificity is 100%. It's a cheap test. So that is something which Bangladesh can ask its government to allow. Antibodies tests are also cheap tests. It costs 400, 500 rupees, but there you have some idea. Another thing which is very important is that all of you as a government policy, you should ask the government to declare the CT value of RT-PCR. Now, what is CT value of a RT-PCR is, the CT is cycle threshold. So when you do a RT-PCR, there are 40 cycles. When you do amplification and when you do extraction, there are 40 cycles. In the first cycle, if the virus is detected, it means the viral load is very high. If the virus is detected on 40th cycle, you say indeterminate. You say it may be a false positive. Therefore, higher the CT value, lower the viral load. Lower the CT value, higher the viral load. Therefore, we are recommending to the government. Government has not yet come out with the guidelines. So now we are insisting with the laboratories that we write down as a prescription RT-PCR with CT value. So therefore, we are telling them to the patients that don't get a CT or CT value. Now, we still don't have data about the viral load importance clinically, but there is some importance of it. If a patient has a very high volume overload, and then you have some public health justification in asking him a strict isolation. And if you say it's a very low viral load, suppose the husband and wife, both of them are very high viral load, they can stay together, but the husband of viral load is very high, and the wife is positive with a very small viral load. We even tell them that both of you live together, but use masking and maintain a social distance. These are theoretical observations. Time will tell us the value of CT value. This CT value is not being discussed by Hong Kong, Singapore, because most of them are nuclear families. In US, they are not giving importance to it because they are nuclear families. In joint families, CT value becomes very, very important. That can be another thing which you can ask the government, that every RT-PCR lab should give you a CT value. And then you have to come back with your own observations. We are observing in India. I am not giving any recommendation, but RT-PCR CT value is going to become an important issue. That's another thing which you can ask the government. Another thing is that only those cases who needs a ventilator should be admitted. Rest all can be managed at home. Regarding HCQS, ivermectin, treatment doesn't matter. Leave it to the doctors to decide what they want to give. It doesn't matter.
So, by the way, in India, in the house also, they are just observing this social distancing, and is it advised for this year? This
See, it is mandatory to use a mask. 2 days back, Indian government brought another controversial order, and that order was that general public should not use N95. I think that government should not declare such types of, they should say mask, ask your doctor. Government can't decide about a particular individual mask has to be used, because which mask has to be used has to be decided by the doctor, treating doctor. Mask is individualized. It cannot be generalized mask. Say, for example, if I am a asthmatic, if I am allergic, if I am COPD, I have to use
Yeah.
an N95 mask because I also have to protect myself from pollution. So for me, infection is not important. I also have to protect myself from pollution. Why should I wear a non N95 mask? Then there is a controversy: is N95 with valve and N95 without valve. Now without valve, with valve is for when I go outdoor. I have to wear with valve because without valve, I cannot wear it for more than half an hour, 1 hour. I will get suffocated. So when I am in the open atmosphere, I have to use a N95 with valve because my carbon dioxide should go out. And if I'm using outside N95, because there is a general statement that the N95 with valve is harmful. These general statements cannot come. So therefore, masking policy will be masking. Which masking has to be decided by the doctors and the patient themselves. It has to be based on the clinical condition of the patient. If you are allergic, if you are asthmatic, you need a mask to prevent other allergens than coronavirus. So therefore, somewhere or the other, the autonomy of the medical profession has gone during COVID era. That has to come back. The governments are dictating how to treat, which I probably see is no reason for the governments to dictate us what to do, what not to do. Their job should be only limited to prevention, guidelines, focus, and it has to be on the doctor's autonomy to decide on a case to case. There's no government to say don't use ivermectin. Government can put down guidelines, but it is individual doctor. Say, for example, my patient needs a albendazole at this particular moment. Suppose my patient needs a deworming. If I prefer ivermectin over albendazole, it's my decision. The government can't say that why you haven't given, why you should give ivermectin or not give ivermectin. It has to be a professional autonomy. I know that Russell very clearly says the term broader good, but broader good comes only if my treatment is going to harm the third person, not other way around. Government can't interfere unless I'm spreading the infection. My action is harmful to the third person, then only government should interfere.
Thank you, President.
Yeah.
Just a short comment, Mr. Chairman. One thing I agree with Aggarwal that government has to give the guidelines and not to the dictation that how the patient should be treated, because government has to behave as government. And secondly, we hear in Pakistan that it was very unfortunately, and I go a step forward, step ahead of the president, what he says that the government, that the undue interference by the court of laws, it is also creating a problem. Here in Pakistan, we suffered. 2.5 months ago, there was a lockdown, and by the court, it was been declared that there should be no lockdown. And we have a lot of number and increase in the disease by the COVID-19. And my point of view is that the courts, they should act accordingly. Health is not their issue. Moreover, the pandemic, and as the American judiciary, they say that we are not expert in health. And I think that we appreciate it, at least here from Pakistan, that the courts should not interfere in the health issues. And as Mr. President Aggarwal says, that the government also has to give only the guidelines, but not the method of treatment. Secondly, the isolation as Indian, some courts have said that isolation at home. Here in Pakistan, that isolation in home, and we as Pakistan Medical Association, we demanded for that. And we have come with the government that if a person has the capacity or have the resources to be isolated at home, that mean by that he can stay in a single room. And hence people are very poor over here, and joint families there. So a joint family with the 10 or 15 people living in a single room or 2 rooms house cannot be allowed to be as the isolation at home. This is what we concluded over here in Pakistan, that if you have the capacity to be isolated at home, then yes, that can be. But if you do not have that much facilities or resources, then it should not be allowed. Thank you, Mr. Chairman.
Just want to add,
Thank
the
you.
Supreme Court yesterday in India has given a decision that policy decisions on COVID-19 will not be entertained. Yes.
This is good. I think, Mr. Chairman, I just want to add something that this is very unfortunate that a medical treatment is being intervened by the government as well as the court. So this is a domain of the doctor. The doctors or the medical professionals should play their role, not the government or politicians or any other uh, uh, rather courts. So this is what the Dr. Nizami said is absolutely right. But one thing I must add that I don't know in other country, but we have a larger number of home isolation, and we demanded from the government that just take on board the general practitioner, the family physician on board, so that they monitor them at their respective areas. The general practitioner are very much aware of the families, so they can go and examine the home isolation patient, and they can monitor them. So, but in Pakistan, it's not happening. But the people are in contact with their own doctors, or they know somebody. They monitor. They ask on telephone, or sometimes they go. But there is no system here in Pakistan. But I don't know who is monitoring home isolation in other country, if anybody share.
Perhaps Dr. Sajat, in Singapore, the home monitoring is actually done by security people. So I'm talking about just enforcing home quarantine, or what we call stay home orders. The medical side of it is we are not putting people at home to isolate when they have the illness. Of course, we still ship them out to a facility. Thank you.
So in India, there are a couple of types of home isolation. One are under the observation of the government. So Delhi government has tied up with an agency who at the moment are managing 50,000 home isolation people. And their job is to, with telemedicine, contact them thrice in a day. That's how home monitoring is being done in Delhi. But and they also put a badge outside their home that he is under home quarantine. The neighbors are being told that he is under home quarantine. So it is a duty of the neighbors to look into for their own protection. That's ethical or unethical is a separate issue. But government is supposed to call them thrice in a day to find out how they are doing.
Aggarwal, I'm sorry, Mr. President, this is what we are going to create a stigma in the society.
Yes, I know.
That if the security is over there and you are going to living over there, so that what in Pakistan, and we opposed all that. And that was one of the reasons that people were not going for testing and so, yeah.
Agreed. I said the same thing. This is a ethical or unethical is a debatable issue.
Yeah, it is very unfortunate.
Well,
yes, Dr. D'Souza. Yes.
But I think if the government actually would have extended support, rather it would not be a stigma actually. Yeah, what I feel, the government would have extended more support to them so that the society takes them that way. But
no,
sorry,
Mr. Chaudhary, it is the people we living in a society, coming a police to your door, and it is not the developed country, and you cannot compare with all. Anyhow, thank you.
Jamal, you already have said, Jamal, you yourself said in your presentation that doctors were stigmatized. Same way people are getting, non-doctors will get the same stigmatization.
Yes.
I think,
Dr. D'Souza, yes.
Yeah, I just happy to join in here, listening to what all of you are saying. One first thing is that what Dr. KK said, we talk of 20% asymptomatic. Now, when I look about it, I think what he's saying is right. They do have symptoms, but it's not considered to be of, and that we have found in Melbourne, that period is probably they are more infectious, and that's probably caused. So now there's a whole area of trying to identify this business of asymptomatic being the time. So now, in Australia, if you even have, before you even get the test, they're giving you some money to stay at home, not to go out until you get the result, right? So you can claim some money. Irrespective of all that, one of the things I think, Dr. KK, talking about putting this board that someone has got the infection. That is from, I mean, the government has got from an ethical perspective, that is stigma, privacy, all these things are being, and I think you said that you opposed it in Pakistan. Is that right, Dr. Ashraf? Is that right? Did you all oppose?
Yeah.
Yes, that is absolutely ethical, because here they don't, you're not told, that is very highly held. I mean, they are monitoring and all that. Now they even have, as Chong has just said, the police will, if they don't respond, the police will come to your house. From yesterday, it's been, or the defense personnel will come to your house, but they don't tell you who's got it, and that's not told out. They only have a number of people in, say, so many in that post suburb, in that postcode, or that's available for you to know which areas. And of course, what has happened here is that we are having only in now Victoria, we had an outbreak into the old age, or we call the homes. Now, unlike Indian, here we have first of all an aging population. So you've got a bigger group, and that has become an issue because, again, now in Melbourne, more than 50 homes have become infected, and the infection has come through people who are working there, working in multiple, doing one shift in one place, one shift in another place. So now they've asked them not to do that and are willing to pay them for that not to go. So they have transmitted, and now that has affected the mortality too. Now suddenly all those 70, 80, 90, this group of people, the outbreak seems to have gone there, but of course in this one state. Three states have no virus. They've fenced off. So that's the situation here. But I agree with you that there's ethical issues of Universal Declaration on Bioethics and Human Rights. Article 11 is stigma and no non-stigma. And I think the Indian program of putting that was shown on TV in Australia, what was happening. As the corporation or whatever, they're putting a green board. They showed it on TV here, what was happening there. And of course, it leads to everyone. There's a discrimination because they interviewed someone who was living in a house, and he was saying that they're not even getting vegetables. The people is not willing to give them things and so forth like that. So I think that's absolutely right. But you can't do anything because law supersedes ethics.
Quite right.
So
Thank you very much. I think we've come to the end of our 1 hour. So I think we always have a very good discussion on Saturday noontime. So I think without much further ado, we've heard from Dr. Jamal, our president, and all the other members of our group. And we look forward to having a discussion next week. I think the issues of stigmatization and ethics and interference in professional autonomy are all very real, especially with certain governments. So these are some things that we have to always be on the alert and for and to combat. So, President, do you have any more things to say about next week's presentation?
Next week, we are going to have me presenting the India, Pakistan, Bangladesh, Nepal, Sri Lanka aspect. Dr. Chong will present China, Korea, Singapore, then those countries, Taiwan, that data. And then one of us is that Dr. Russell or somebody from his side will present the data from New Zealand and from the Australia counterpart, because their mortalities are different. Yeah. And we still don't have anybody to present data from Iranian countries. If somebody can present, somebody can volunteer. Dr. Ashraf, can you volunteer presentation of data of Iranian countries?
honor, Mr. President, I'll do so.
Yes. Let him present the data of Iranian countries. You go to World Meter, you will get all the data there.
No worries, no worries, no worries. I'll do it.
So that we can have CMAAO countries participating into 4 parts. And let's try to see why the modalities are different, how the policies differ into that. And before I say goodbye to all of you and invite for a cup of tea in your own house, 2 more announcements. Mari, yes, you have to be. Mari, you want to say something before that? She hasn't spoken.
President Saab, can I say, I have a suggestion.
Yes, please. Before that, Mari, if she wants to speak a word.
Yes, just a quick notification that thank you very much for the interesting information from the Bangladesh. And in Japan, we changed the expanded the scope of our testing. So number of the tests positive and testing positive patients are increasing. My impression, more asymptomatic people tested positive compared with other before. We are not yet analyzing in detail. Maybe we have to be very careful that maybe the PCR test is just tracing the remain of the viruses. Thank you. Thank you very much, always.
Dr. Sajjad?
Yes, I just want to request Mr. President to just increase the participants, the CMAAO country. I think we are having a less number of participants.
I will try. I will call myself this time to everybody. Let me call everybody. The only thing I just want to add, which is that every day at 7 o'clock in the evening Indian time, I've started a YouTube Facebook show, which is attended between 10,000 people to 100,000 people, because I've only done 5 shows. Some show has crossed 20,000, some show has crossed 100,000 people. So all of you, anybody who feels that they can be a part of my panel and discuss out, please contact me. It's half an hour show every day, 7 o'clock Indian time. So I would like one by one, every day it's a daily show. So anybody who is free on a particular day, please send me a WhatsApp. Saurabh will interact with you on my behalf. Saurabh is my son, who is handling the whole thing.
Could you please repeat the time?
7 o'clock to 7:30. It's a show where I discuss about one topic with the experts. So thank you, everybody. Thank you, Sanchita, for making it happen.
KK, can I tell, our program that goes on for, this is the 18th or 17th, KK has agreed that he's going to speak tomorrow, on the ethical issues involved in managing, and particularly from this region. And we have Professor Thornton from Florida, who's going to chair and compare what they're doing in the United States. So that will be, I suggested if someone wanted to join, because KK
so
is
anybody of you want to
representing CMAAO.
Local issues faced by CMAAO countries.
Yes.
It's a tomorrow
is 5 o'clock.
5 o'clock. If
5 o'clock, yeah, the usual.
Please send the link.
If anybody else also
I sent it already. I sent it.
Panelist,
Yeah.
kindly volunteer. If anybody also wants to talk about some special ethical issues in your own countries, kindly participate.
Yeah, I know Dr. Ashraf usually joins regularly, but the next one is on nurses from all the countries. They'll be going to talk on their issues. And I think down the track, very interesting, the inter-religion faith are going to come in from around, from the United Nations inter-religion and faith group is going to have a panel discussion on with this through the UNESCO program. Yeah.
So thank you very much. See you next week. Enjoy a cup of tea.
Thank you very much. Thank you, everybody.
Thank
you very much,
President. Thank you.
Bye.
Thank you, Jamal, for the wonderful conversation.
First sip of tea you take, you say cheers, CMAAO.
Thank you.
Thank you.
Remain
Cheers.
safe. Remain safe.
Today is the courtesy of Aggarwal.
Thank you. Thank you so much.
Thank you so
Thank you
much.
so much.
Bye bye.
Bye-bye.